Nee, ich habe die gleich gesehen.
Nicht irgendwas hacken? Ja, I'm good. Just. I'll see if I find some love.
Yeah. If you do have, that would be great.
Oh, you mean?
So you would, yeah. And what's your decision? You're trying to do mental health stuff. Would you work?
I'm working with Albrecht.
Oh, okay. With like doing how thank you for inviting me. Yeah.
So, I remember.
Sorry?
So you'll go back tomorrow?
No. I maybe a different one. I'm here because my husband is actually on sabbatical here in Heidelberg.
Hold on.
So we're
No,
living in the
I-
guest house, which is just
It's
there.
okay.
I can almost not quite. I've got the face.
Yeah. Why not just?
Yeah. Someone else. Yeah. So it's nice to be able to do something as well.
Yeah, and I think because we have also been, we have this colloquium on migration.
Yes.
And Claudia Reisner.
Yes. She said she's traveling today. She couldn't make it. She said she couldn't.
See, because
She invited me, but then she
Exactly, so I know
and then
she will.
Janine Benson Martin, who was also involved in inviting me, also can't make it. And Jamila Nabieva, she was also traveling today. So they all sent me messages, sorry we can't make it. Can we have the slides? But that's
we also basically, with hopefully with your permission, we can also.
yes.
Okay.
I don't think so, but it's fine. It's 1.5 minutes and there's no talking, it's just music. So it would be atmospheric. But
Okay. Let's just wait for 2-3 minutes because it's 15. So.
check this out.
Wir können ja die 2-3 Minuten.
Ja.
Ne?
Ja. Also willst du anfangen?
Was ist?
Willst du anfangen?
Okay. Ja, wir lassen die Tür noch ein bisschen auf, dass noch jemand reinkommt.
Ja.
Alles gut.
So hi everyone, I think we can start right now. Today we have Erika Boya as our guest lecturer. She's a public mental health researcher, so she's very interested in the development of mental health projects and as well as their evaluation. She has worked for around about 10 years in South Africa, and she got her Public Health Award in 2009 from the University of Cape Town, and quite recently you got your PhD in 2018 in psychiatry. And you've also been, from 2011 to 2019, the researcher and project manager for the program of improving mental health care. And this is what you're going to talk about today. So I'll give the floor to you.
Thank you. Okay, so very nice to be here in Ireland. So today I'll be talking about this project that I was involved in and giving you a little bit of an overview. I was thinking about what might be interesting. So I'm giving you a big idea of what we did, And then there's lots of papers that are published about the project, so you can go and have a look and see if there's a specific area that you want to know more about. So where did this project come from? Historically there has been quite a big dichotomy between mental and physical health globally. But over the years in developed countries, so high-income countries, this has been closing and mental health care has become more and more integrated, or at least referral systems to specialized care have been more accessible. In the last 20 years, with the emergence of the measurement of the global burden of disease, it was quite startling that around 9.5%, that's about the estimate at the moment, of global disability-adjusted life years are attributable to mental, neurological, and substance use disorders. And many of these are in low and middle-income countries. So there's increasing evidence that poverty and mental illness are very closely linked, and there's a bidirectional vicious cycle which perpetuates both. Globally, in both high and low middle-income countries, there's higher premature mortality for people living with mental illness and poorer physical health as well. There continue, again globally, to be high levels of stigma, discrimination, and human rights violations towards people living with mental illness. In low middle-income countries, less than 25% of people who are living with a mental illness have received some sort of health care, and only about 2 to 4% receive what we call minimally adequate treatment, so that's enough treatment so that they're likely to get better. This is compounded, or this is a result of low human and financial resources for mental health care. So, for example, in sub-Saharan Africa, less than one mental health care worker is available for about 100,000 population. So very low. And funding is also very low. So even if you look at the percentage of the health budget which is dedicated towards mental health care, it's much higher in high-income countries than it is in low and middle-income countries. One of the big problems in terms of human resources for mental health care is that even if we do train specialists, by mental health specialists, I mean not just psychiatrists, but clinical psychologists, psychiatric social workers, but psychiatric clinical officers, which work in some African countries and are the equivalent of a physician's assistant in the US, so somewhere between a doctor and a nurse, psychiatric nurses, and other people who are skilled specifically in mental health. Even if we train people for to treat mental illness, there still won't be enough to get the ratio that we need to treat people adequately in low and middle-income countries. I remember when I first started this project, I was speaking to a colleague in Ethiopia, and Ethiopia has a population of 80 million. And I said to him, how bad is it in Ethiopia? And I think at the time he said to me, I can count them on my hands, all the psychiatrists in Ethiopia. And the last time I talked to him, which may have been 1 or 2 years ago about this, there were 26 psychiatrists for a population of 80 million. So it's getting better, but it's not enough. So in the context of this, there obviously does need to be more that is done for mental illness. And there's an increasing evidence base for effective interventions that can be administered or given by non-specialist health workers. So using principles of task sharing, which is sharing roles that are normally at specialist level with generalist healthcare workers or other lay or less trained health workers. There seems to be evidence that these could be effective in reducing mental ill health. So in the context of this, and at the same time, in 2007 there was a Lancet call to action in a Lancet series which introduced the problem of global mental health. And a few years later, the WHO published and the Mental Health Gap Intervention Guide, which is a guide which helps primary healthcare workers to identify and detect the 10 most common mental, neurological and substance use disorders. And this was based on quite a rigorous evidence assessment using the GRADE methodology, but there wasn't really an idea of how this could be implemented in practice in low resource settings, especially at a larger level, thinking about scaling up and affecting treatment coverage of mental illness. So that's where Prime came along, and I'll show you the video. The sound's not working. I just want to show you it's really, the video is just beautiful. Just to introduce you to the program, and then I'll keep talking. So the people involved in Prime are here in this picture. This was at our annual meeting last year in March. The program the funding officially ended in March of last year, although many papers are still being written, as is always the case with projects that keep going. So the people that are involved in the project, I'll show you on the map. But first, I can just show you here. This is the CEO, Crick Lund. He's based at the University of Cape Town at King's College in London. This is Vikram Patel. He was one of the research directors. Mark Tomlinson, who was the research director for the first 6 years of Charlotte Hammond up here. And these are the PIs, the principal investigators for the project. Oh, he's not here. Anyway, Abhigata Kami, who's not here on this picture. This is the principal investigator for Ethiopia. Then Rahul Shadai is down here for India. Mark Jordan's up here, Nepal. Inga Peterson here for South Africa. And Fred Kigozi from Uganda. And there's Abigail, I just missed him, it's in the middle, so that's for the Ethiopian. So the way that the project worked, just to give you an orientation, is it was led from the University of Cape Town, and I worked together with Crick Lund there at the University of Cape Town. And then in each country we had a partnership between either an academic institution and the Ministry of Health, or an NGO and the Ministry of Health. So in Ethiopia it was the University of Addis Ababa and the Ethiopian Ministry of Health. In India it was two NGOs actually, Sangha and the Public Health Foundation of India, and the Madhya Pradesh Ministry of Health, which is the state, where we worked. In Nepal, we worked with the Dutch NGO, HealthNet TPO, and the NGO, their affiliate NGO, TPO Nepal, and TPO Nepal was the implementing partner. In South Africa, the lead organization was the University of KwaZulu-Natal. In Uganda, we worked with Makerere University. In London, we worked with the Centre for Global Mental Health, which is a collaboration of the London School of Hygiene and Tropical Medicine and the Institute of Psychiatry, King's College in London. We worked with the Mental Health, Neurological and Substance Use Department of the World Health Organization, specifically Dan Chisholm and Neeraj Chowdhury, and we worked with an organization in the first 6 years called Basic Needs, which is a mental health and development NGO. It's actually run from London, but the partner that we worked was based in India. So the research phases for our project, so the project was initially funded for 6 years, and the majority of the primary research that I'll be discussing was conducted during that period. We got an additional 2 years of funding to wrap up some of that work and do some additional smaller projects, but I won't discuss those today. So there were basically 4 phases. The one is to develop evidence-based district-level mental health care plans in 5 countries. The second one was to implement those, and we implemented those in 37 facilities across the 5 countries, and we scaled up to another 94 facilities across the 5 countries. And again, I'm actually only going to focus mainly on the first 2 parts of that, because that's where we've got the most information, and also because it's quite a large project. The scale-up data is still being analysed and written up. So in terms of where we worked in Prime, we worked in Sodo district in Ethiopia, in Sahor in India, in Chitwan in Nepal, in Dr. Kenneth Gwanda in South Africa, and in Kamuli in Uganda. And these were relatively representative districts for the countries. Nepal, in Chitwan, a slightly higher resource than the rest of the country. So what you can see here, I think the main takeaway is to look at the population, again, and the mental health specialists. So in Ethiopia, there was no any sort of mental health worker in a population of 165,000 people. And the closest anyone could get mental health services was in the next district, which is Buttigieg, which is actually a site of one of the Buttigieg study, which follows people living with mental illness over and has done for a long time. We worked with the Ministries of Health to determine which districts we should work in, so they suggested to us where we should work. And here's some of the districts. Up the top left is at a community advisory board in Sodo, Ethiopia. The right and the bottom left are pictures from Kamuli in Uganda. And to the right here, we have the Prime partners visiting a clinic in India. You'll notice they're all wearing face masks. But it's because there was a flu epidemic on at that time, so they needed to wear the face masks, but nothing to do with mental health. So what did we do, and how did we develop these evidence-based district-level mental health care plans? It was a long process, and I'll talk about some of the bits. The first was really to establish community advisory boards in the districts. It didn't work everywhere, but in some cases where it worked very well. So in South Africa, it didn't work because there were already existing clinic oversight committees, so we found a way to work with existing structures, but in other cases where there weren't these oversight bodies, we created one specifically for Prime. We had a way of prioritizing which mental disorders to focus on, and that was either at the national level with the community advisory boards. In one country, they did a formal process as well with a Delphi study to determine which disorders to use. We did some literature reviews, a situational analysis, which I'll talk about, some qualitative research, the development of a theory of change. We developed a mental health gap, MH gap costing tool, and piloted the plans in some districts, and then made some facilities and made some changes. Or I shouldn't say the whole plan, some bits of the plan. So in terms of literature reviews, some of them were systematic reviews and other reviews on the topic. For example, one review which was in the Lancet series in 2011, looking at poverty and mental illness and breaking the cycle of poverty and mental illness in low-income countries. Another one on estimating the coverage of mental health programs, and several others that we were part of. In terms of the situational analysis, we did this in every country. It was a collection of secondary data from district and national level sources, and looked at 6 domains. One is looking at the relevant context and other health issues that are going on, looking at mental health policies, plans, and politics. Mental health treatment coverage, to see what data exists on mental health treatment coverage, and not a lot was the answer actually, but just to see what does exist. District level health services, both for mental health and for other general health services, and how they're organized. Community level resources and services, and monitoring and evaluation of these services. And basically we found that there was almost no mental health care, and the resources for the provision of mental health care were low. There was no budget in any of the countries for mental health, and the only country that had some mental health in primary care was in South Africa, which we anyway knew was going to be better resourced than the rest of the other 4 countries. And in all the prime countries, the human resources were less than 3 per 100,000 population. We did qualitative formative research with a range of stakeholders at national, district, facility and community levels, looking at key themes such as demand and access, detection and identification of mental illness, pathways to care, service delivery, accountability. And there's lots of papers that have been published from that. One of the things that we were looking at was, for example, the feasibility and acceptability of task-shifted mental health care. And we looked across all countries for this one analysis of the data, and we found that stakeholders thought that task-shifted mental health care was likely to be acceptable and feasible as long as there was adequate supervision, training, medication, and resources for that to happen. And here's just another example of another study which analysed the data from Nepal, which looked again at demand and access to mental health services, and to try and understand what the barriers were, such as pragmatic barriers, such as how to get there, childcare, but there were other barriers such as mental health stigma, lack of awareness, and we actually asked stakeholders to propose strategies to work out how to overcome barriers. So they suggested things like awareness raising through respected community figures, responding to needs for openness and privacy and confidentiality, working with local notions of stigma. So in Nepal, there's quite a strong dichotomy between mind and body, and there's not a general acceptance of taking medication or any sort of treatment for a mental health issue, and building trust in mental health services. So we then took those suggestions and built those into how we developed the mental health care plan in Nepal. And then the MHGAP costing tool, I won't go into detail, but it was basically developed to look at what the costs would be in terms of monetary costs for medication and staff for the implementation of the mental health care plan, but also the human resources requirements and what that would be needed at scale. And then the other thing that we did, which I was quite involved in, was using something called theory of change, which is an outcomes-based approach, which describes how an intervention brings about specific outcomes through a logical sequence of intermediate outcomes. And it has been used in the past in evaluation, and not so much in research and understanding a framework for research. So what we did in Prime was actually to develop a theory of change for our program and use it as a framework for how we developed our research framework and our research designs. So we developed the theory of change initially in Goa in 2011 at a meeting that we had, and we developed, and then we went away, and then in the prime countries, the prime teams in each country facilitated district-specific, they're not district-specific, they facilitated theory of change workshops in all prime countries. There were 13 workshops across the 5 countries, and in each country they had different ways of organizing it. So in some countries they only worked at the district level, in other countries they worked at national level as well. And then this fed back into our overall theory of change, which we refined, and then we used that to develop indicators which we used for our study designs. So I'll just show you. I know you can't read this, and I've been told that one must never put up a slide that you can't read, but here it is. It's impossible to get it much. This is the summary version of our theory of change, by the way. Yeah. The other one is much larger, but I will, because I know it, I will read up to you what's on there. So the impact on this slide says improved health, social and economic outcomes for people living with priority disorders and their families and carers in the district. Then if you go one back, it says increased effective coverage of evidence-based treatment for health, evidence-based mental health services. Sorry, I put on mute for help.
Increased, and then if we go back on improved outcomes for people with mental disorders treated by their program and their families and carers. People with priority disorders receive treatment as intended for the required duration and are adequately referred. Services are accessible, affordable, and acceptable. People with mental disorders are identified and diagnosed in facilities. And if you go down below, people with mental disorders are identified in the community. People with mental disorders are willing to seek treatment. The community is aware of mental illness and stigma is reduced. And then at the top you have things around service providers are able to diagnose and treat priority mental disorders, psychosocial interventions are available, adequate ongoing management, quality control, and clinical supervision, essential medications are in place, functioning medication supply chain, program coordinator in post, service providers in post, and the program is approved and budget is available. So that's how we sort of thought that things would happen at the district level. And then what we did was we said, okay, well, how do we measure that? So we, for each of those boxes, we came up with an indicator, and then we developed 4 different study designs to measure what was going on. So for the increased coverage, effective coverage, we worked, we have a community survey which looks at the change in treatment coverage of mental illness before and after Prime. For the question about do people treat improved outcomes for people living with mental illness and their families, we looked at, we did treatment cohorts which we followed over 12 months of people who entered care to see if they got better. To determine whether primary healthcare workers could identify and detect people living with mental illness, we did a facility detection survey, which looked at whether or not people with symptoms of depression or alcohol use disorder were identified in the clinics. And then the case study we looked at was basically all the other stuff up in there in the green, so that looked at training and supervision, service providers and post, program management, medication supply, and a whole lot of other things that we were interested in. So we did that. And then just to say how it worked in relation to the implementation. Sorry, the color is not great on the screen, but the implementation of the Prime Mental Health Care Plans is that grey box, and the top line is the community survey. So we did that before and after the Prime Mental Health Care Plans. The facility detection survey we also did before and after, and in some cases people did one immediately after implementation. Then the case study was done at regular intervals throughout, depending on the method. And the cohort study was done after implementation, but following up people 3 times, so baseline, midline, and end line. Mostly it was 12 months, with either 3 or 6 months, depending on the disorder for the midline. Okay, so the other thing that the theory of change, so we talked about all the ways to develop the mental health care plans, and we then also had a look at what things were needed to move from one to the next. So if you go back, where the arrows are, we said, okay, how do we get from one to the next? And we came up with a mental health care plan which described what we thought would need to happen. So the way the mental health care plan is organized is that we had 4 levels: healthcare organization, specialist mental health services, healthcare facilities and community. And then we had 4 sort of vertical columns: awareness, detection, treatment, recovery, and enabling factors. And then in each of these we said, well, what do we need to do? What's the end point or the function of this? So we need to engage and mobilize district stakeholders, or we need to increase awareness of service users and providers. But because we were working in 5 different countries where the contexts are vastly different, we didn't want to say, well, here you need to use this specific tool, and you need to go out and you need to screen everybody in the waiting room, or you have to use this MHGAP tool, or you have to increase awareness in the community in a specific way. So what we did is had this matrix, and then in each country they used their qualitative research and the other research that they'd done, the prioritization, to actually work out what they should do in each of those countries. So I'll use an example. In the healthcare facilities in the detection section, so that's, yeah, there, detect, screen, and assess for priority disorders. In Ethiopia, they largely used the MHGAP at facility level, which was adapted and translated. In India, they found that actually the MHGAP wasn't enough because the medical officers weren't necessarily doing it with all patients. So they would have a case manager who would screen people using the PHQ-9 or the audit in the waiting rooms, and then they would refer to the medical officer who would then conduct the MHGAP assessment. In Nepal, they used a translated and adapted MHGAP. In South Africa, they integrated the MHGAP into another tool that was being developed at the Lung Institute, which was then called Primary Care 101, and is now called PAC. You may have heard of PAC. It's been rolled out in quite a lot of countries. It's a manual for primary healthcare workers, but rather than just like the MHGAP having 10 mental, neurological, and substance use disorders, it's got everything. So TB, asthma, back pain, cancer, it's all included. So mental health was just a component of that. And then in Uganda, they used, again, an adapted MHGAP. I'll give another example. So improved case detection in the community. And I'll show you a slide later, but in Nepal, for example, they developed a community-informed detection tool which had pictures of people living with mental illness and their stories. And then they trained community health workers and traditional healers and other senior people in the community to identify and detect people living with mental illness and refer them to the community. And they had something similar in Ethiopia, although it didn't have a specific picture or a tool. In other countries, they did some training. In India, they had mental health camps, so they went out to villages and would do some screening or talk to people about mental illness and then refer people to the clinic. So it was different in every country. So when I show you the results and you wonder why things are different, you can think that maybe they're different. Things might have happened quite differently in every country. The one thing that also happened differently, I have to say, is that the resources that were used from the project perspective were different. So how much the project provided versus the health service. So in some countries, the supervision was provided by the team, the prime team, or people paid by the project, and in other countries it was provided at the Ministry of Health, or there was a combination of both. Similarly for training, so in some cases it was directly training from the prime team to the healthcare workers, and in other cases they used a train-the-trainer type strategy where they trained district health workers to implement. So this is also, some of the things we're in the process of unpacking at the moment, actually. So just to give you an idea of what the results were from the baseline studies before we started, so we did the community survey in 4 countries, and the depression population treatment coverage was between 8.1 and 23%, and for alcohol use disorders it was 2.8 and 5.1%. We didn't look at effective coverage. And clinical detection for depression was between 0 and 11%, and for alcohol use disorder between 0 and 7.8%. So those are people who are coming into the clinic who have symptoms of depression and alcohol use disorder, who are then detected by the healthcare worker. So it's low. Okay, then we went ahead and we implemented the project in 38 facilities in the 5 countries, and we focused on 4 priority disorders: psychosis, depression, alcohol use disorders, and epilepsy. You might, I don't know what it's like in Germany, probably epilepsy falls under neurology, but in some countries in Africa and Asia, the epilepsy falls under mental health. And so it's included in the MHGAP program, which is why it's here. So you can see we had quite a lot of mental health visits. So in this, we had more than 20,000 mental health visits during the implementation phase of PRIME. In Ethiopia, we had 8 facilities and more than 4,500 visits. In India, 3 facilities and almost 4,000 visits. In Nepal, 10 facilities, 4,500 visits. South Africa 4 and 572 visits, and in Kamuli 13 and 6,774 visits. So what were the outcomes that we saw after Prime was implemented? So basically, you can see here on this table, so treatment coverage psychosis wasn't estimated through the community survey, but through other methods using service utilization data. And there was a change in coverage for psychosis in Ethiopia and Nepal, which is the only two countries we looked specifically at that. For depression, there was a change in Nepal. They actually used another approach to also measure treatment coverage because so they showed that in the community survey there was no significant, there was a change in treatment coverage, but it wasn't significant. But they also looked at service utilization data and estimated treatment coverage from that. So it was significant only on the service utilization data and the alcohol use disorder as well. But in the other countries, there was no significant change in treatment coverage for depression or alcohol use disorder. Oh, sorry, that AUD, actually that tick should be a cross. It's not. There was no change in Uganda. And then at the facility detection level, there was a change in detection at the facility in all the countries that except Ethiopia. So in Ethiopia, they did a facility detection survey quite soon after training, and they found that there was no change in the ability of clinicians to detect depression depression, and they didn't do alcohol. So, and then they didn't do a follow-up survey later because there was no point, there was no change. That's it was very interesting and quite training, and then tried to investigate why people weren't being diagnosed at the facility level. And so they applied for some funding, and now they're doing a whole other research project on that. But basically the ideas are that it would be around cultural ideas of what depression is, whether it's a medical problem, whether it's thought of in a different way. Sometimes people think of it as a cognitive problem because people are thinking too much. Sometimes it's thought of as a social problem because it's related to poverty and other factors that are going around. So the depression was, so that's being investigated. In Uganda, there was a change. You see I've got ticks there, but it was only at the interim, it was only straight after the training, and when they looked at it at the end of the project, the change had actually not become significant anymore. So, and even for the facility detection, where it seemed to increase quite a bit in the countries, I had a look today at the papers, it was around 20 to 30% of people who are screened positive who were detected. So it was still actually quite low. So just to give an idea of what the cohort studies said. So the cohort studies, we looked at people who had entered care, and then we followed them up. We assessed them at baseline at 3 or 6 months and at 12 months. And we wanted to see if there was a change in clinical or functioning outcomes. And there was a change, so there's depression for the different countries. So in India, there was a change in clinical, for depression, there was a change in clinical but not functioning. Nepal, there was a change in clinical and functioning outcomes, in South Africa as well, and Uganda as well. For AUD, there was a change in India in clinical but not functioning, and in Nepal, both clinical and functioning outcomes. In Ethiopia, there was a change of psychosis in clinical and social outcomes, and in Nepal, in clinical and functional outcomes. In Uganda, in functioning outcomes, they didn't look at clinical. And then for epilepsy, there was, interestingly, in Nepal, no change in clinical or functioning outcomes. In Uganda, there was a change in clinical outcomes. So, it's not all rosy, but it does start to give you a picture of that things do work, but not in all cases and in all situations. But we do have improvement in clinical and functioning and/or functioning outcomes in most of the countries for most of the disorders. So what's next? So I said the project is officially over, but now that we've got these results, we need to find out what happened and why. So we're actually going back to the case study and looking at were people, like how well were people trained, was it implemented well, what were some of the issues with implementation, and there's a whole series of papers coming out now which are really trying to unpick the implementation and the quality of the implementation. So for example, Rahul Shidai has just published a paper in EJ Site Open, and he used the consolidated framework for implementation to understand the implementation processes for Prime India. And he found that they used process maps for clinical interventions, which were really helpful. And they had implementation support from an external team, including supervision, which helped to address the implementation barriers. Obviously, training was really important, and so were the enabling packages to strengthen the health system. But the thing where their mental health care plan didn't work as well is that at the community level, they just didn't have the resources to go out into the community. So they did some community level work, but it just wasn't enough to actually make a big difference. So the demand side was really missing from their work. Their model was actually quite different as well. They only really worked at district level hospitals, so even it was primary care for them, so it wasn't specialist services, but it wasn't the same level of primary care that the other countries worked at, which were the direct, the first point of call primary healthcare centres. So the lessons learned, it's feasible to implement mental health interventions, although it's tricky and there's still all of these issues around detection. You know, how do we train and supervise people to detect better? How do we improve the outcomes for everybody across all disorders? How do we make things sustainable? So some of these things happened because Prime was there. What happens when Prime goes out? That participatory development of the district mental health care plans is essential, so using approaches like theory of change or other bottom-up development approaches. And we know that training doesn't work alone. We need ongoing supervision as well as training. In addition to training, reliable medication supply, realizing more and more is demand-side interventions are vital. So interventions which really don't just, so what in Prime we mainly focused on creating the services and making them available, making the medications available. And even though there were some components that worked at bringing people to the facility, it wasn't the bit that we focused on the most. And so these demand-side interventions of creating a need for services are really important. So just there's some two pictures. That's the Nepal Community-Informed Detection Guide, which I told you about. It's got all pictures of all the different symptoms and a story about somebody with mental illness. And that's a picture of Sodo, the Ethiopian district, where they also had the case ascertainment. So I've got a few minutes, and I'll just talk some broad things that maybe the project did that are perhaps interesting to get an idea of the scope of the project. So one thing that the Prime group did really well is to increase research partnerships. So this is a diagram we drew. You can see South Africa, Ethiopia, Uganda, India, and Nepal, and London and Geneva over there. And each of these lines, I'm sorry, it's a bit difficult to see, but each of these lines is if you work on a publication with somebody at a different organization, you get a line. So if there's a paper that has 3 co-authors, you would have one line going up, one line going across, and one going down. So if you had 3 co-authors. So there's not a line per paper, it's a line per link. So that was in 2010, before Prime started. You can see there's a little bit of relationship between South Africa and Uganda. That was because of a previous project. There was quite a strong relationship between Ethiopia and the London School, King's College, a little bit from the London School over to India, but not really a lot. And then in 2017, the picture looks quite different, and we see a lot more publication. And I forgot, I should have actually added, there's another picture which we made, which is where we take away the prime publications, because it makes sense that you publish with each other on the project publications. But actually, if you take away the prime publications as well, the links are still very strong. So the one thing that Prime did was really to help increase this research partnership and working together. We publish quite a lot of publications which go in depth into a lot of these things, so like the qualitative work. And we had a lot of PhD students, so about a third of the publications were actually authored by PhD students. And then there was also quite a lot of policy impact in all of the countries. There was some input into mental health care plans, district plans, policies. In Nepal, they managed to advocate for mental health medications to be added to the free drug list. In South Africa, it's informed quite a large scale of mental health services, which is being funded by the CDC. And then we've informed some more global policy documents. The most recent one was the MHGAP operations manual. So I talked about the MHGAP at the beginning. It's now implemented in 100 countries. And we managed to use some of the lessons that we learned through Prime to inform the operations manual that was being developed. And then you also see the tools that we've used through developed through Prime. So brown is the Prime countries, and green is where we've actually gone out and had some relationships and tried to provide some technical support for mental health projects that people are doing in those countries. And then the blue is the Prime tools being used actively in those countries as well. And this is just some work that was happening towards the end of Prime. Some of the Prime colleagues, there's about 7 or so Prime colleagues who were involved in the Lancet Commission on Global Health and Sustainable Development, and starting to think about social determinants of mental disorders and the Sustainable Development Goals, and how much the social and economic environment that people live in impacts their mental health. And that's really the next step now, to start thinking about how do we impact those social and economic factors. So not just treat mental ill health, but try to look broader than that. So the recommendations is really to invest in mental health by scaling up integrated primary healthcare services, but trying to do that well and carefully, context specific. We still haven't ironed out all the problems related to that. I talked about stimulating demand through community level detection, strengthen the health service system. So one of the problems that we found in Prime was we went in and we wanted to do all this mental health work, but actually the health systems weren't strong enough to do that. So a lot of the work that was being done was around health system strengthening. And child and adolescent mental health is a big issue because a lot of mental ill health is already established quite young. So that by the time people reach adulthood, they already either have an established mental illness or are very likely to get one. Not everyone, but if they have that, the risk is sort of decided quite early on in life. And the other one, as I mentioned, to address the social determinants of mental health. Here are some Prime tools which you can have a look at on the Prime website. It's quite handy. Some videos. There's a nice video, a 45-minute film about Prime. So the little video clip that I showed you, but much longer, and it has interviews and much more interesting. And there's some acknowledgements. So, yeah, thank you.
Yes, thank you very, very much, Erica. It's a very interesting talk. Are there any questions from the audience, first of all? What?
I will start with a more technical question, because you have all this data on percentage of case detection and so on. So you need a kind of methodology to establish the gold standard, so that you can say
Yeah.
There would be so many, and 10% have been detected.
Yeah.
But how could you create, what was your instrument to detect, let me say, the true prevalence?
Yeah, you see, you hit the nail on it. No, that was a tricky methodological problem, and we didn't have the right answer actually. So the way we did it in the project was to use screening tools, which isn't ideal because you have a situation where you screen and then you say, well, screen for example, use the PHQ-9, which is a screen tool. So it's mental distress, and then you see whether people with mental distress are being picked up as having depression. So they are not the same thing. We did do some validation of the PHQ-9. In some countries it was better than others. In Ethiopia it wasn't good, which is maybe why the facility detection survey didn't work. There were lots of false positives in Ethiopia. Whereas in Nepal, for example, it was much better, in South Africa as well, or much better. The problem is that the gold standards for diagnosing mental illness are quite lengthy and expensive to administer because they require a trained mental health, usually mental health specialist or someone who's quite highly trained to administer them. So it was a bit difficult, and we had a lot of discussion, and I'm sure that if we went back and did it again today, we would have used the gold standard and tried to find a way to absorb the cost in the project. Yeah. I did, but even if you do have a look at the numbers and fiddle and take the PHQ validation, some of the prime partners have actually looked at the PHQ validation results and had a look at the detection to see, okay, well, if there are this many false positives, what's then the detection? And I think that was in Nepal, and then it sits around 60%. But of course, you don't, it's just mathematical gains. Yeah, sorry.
Any other questions?
I still have another one.
Yes, go ahead.
Yeah.
So of course, one of the key questions in that field is to which extent you can task shift.
Yeah.
And there is also, I mean, that is interesting in Germany, there is a lot of resistance from the psychiatric professionals, basically to task shift to lower levels.
Yeah.
There is a big professional fight on that in Germany. So how did that work? Because you just said that was part of your intervention, but can you basically make a kind of overall judgment whether generally this task shifting to less trained professionals has been working?
You mean from an effectiveness perspective or from what the psychiatrist thought of it?
No, from an effectiveness perspective, whether that is a strategy that at the end of the day produces better outcomes, let me put it that way.
Yeah, so because we didn't look at effectiveness, because we did treatment cohorts where we just followed them over time, and that was partly because of resources and partly because of the way the plans worked, because they were district level plans and the ministries of health felt very strongly that we needed to implement them. I think the evidence from Prime and from other places is that it can work if done well, but it doesn't always work. I think it has to be done properly. It can't just be a situation where you say, well, I think a lot of people do it because of cost, and they say because it's going to be cheaper to treat people in community, and we're going to shift the costs into the community, and then people are not getting adequate care, but the people who are providing the services aren't getting adequate supervision, they're not getting adequate support. If you think about a clinical psychologist, I don't know if it's like that in Germany, but in South Africa certainly, clinical psychologists have huge amounts of training and then they go into the clinic and they still get clinical supervision really intensely, at least for the first few years of their practice. So it's about how much can you task shift, and also how to what level, and how much training and supervision do people need? So for example, in Nepal, they used community counselors, and they had 3 months of really intensive training, and they provided manualized treatment. And they managed to do a nested randomized control trial in the clinics. I didn't talk about it at all. But the community counselors, so they showed that there was an effect. So that people got better more. We showed effectiveness of the community counseling compared to no community counseling. So I think it does work. But I think the evidence is mixed from Prime and from other places. I think it's easier in countries where the services are not there in terms of the resistance from psychiatrists. So in Ethiopia, for example, then they're not taking business away from the psychiatrist. You're not taking business away from psychiatrists because they're not doing it there anyway. I think the other thing is to think about the severity of mental illness and at what severity is task shifted mental health care okay, and at what point do you need to step up. So using sort of more stepped care models. And there was, we didn't talk about here, but there were mechanisms in there for reviews by specialists for cases that didn't work as well. Yeah. Does that answer your question?
I could see that. I mean, there is another one. I go a bit more into that. For example, do you think community health workers have a place in that overall business mental health?
Yes. Yeah. But I don't think we've worked out quite yet how to do it extremely well. So I think it's about what tools you give them, how you manualize the treatments. It needs to be quite structured. And I think, my personal view is that that it feels a bit naive to take a community health worker who's just come out of school and a clinical psychologist and be able to compare and see whether they can get the same out. And in a lot of countries, that there is only one or the other, but there might be other models. So in South Africa, for example, one thing that they're doing, which is quite interesting, is we have quite a large cohort of Bachelor of Psychology graduates who can counsel, and they have an honors degree, so it's a 4-year degree, but there's no jobs. There's no jobs in the public service. They can only do private counseling. So one of the things they've been working on, the Prime team and through other projects, is actually trying to make places for these Bachelor of Psychology students to provide supervision and support for community health workers. So you don't have a psychologist and then a community health worker, but you have someone in between who can support those processes. Yeah.
And they're quite valuable resources. There are so many more mental health cases that you don't detect or you aren't able to detect because they're maybe still small. You have like mood changes or whatever, but they can quickly lead into depression or severe depressive disorders and whatnot.
Yeah. So the one nice thing that came out of this Lancet Commission report for sustainable development is a much more symptoms-based and sort of transitional, I don't know what they actually called it. It was an idea of mental health where you might be fine and then you might have some risk, you might develop some mood changes and then it might get worse. And so that this idea of that people are on a continuum and that maybe at the level where they have some mild mental distress, some social support is enough to take them back into, a good place. Whereas, if they go further along that trajectory, they might need some more intensive treatment. So it's about thinking, how do we move across those? I think the other thing that we did with Prime was quite binary, so thinking about symptoms or no symptoms. And I think this idea of, it's much trickier to do research though when you're thinking across the spectrum. It makes mental health quite tricky, I think. Diagnosis is very tricky.
Yeah, tricky, but maybe also simple.
Yeah.
Any other questions? Yeah.
Were there attempts, like in the research, to work with the structures that do exist? I mean, like from that people, if they feel a certain way, they would go to see like a
Traditional healer.
traditional healer to work with, like to talk with them to see like, okay, this is, because these are the avenues where people are already going to.
Yeah,
and
so in
also
some
trust.
countries, like in Nepal, they did do this CIDT training with traditional healers. And in other countries, it wasn't as much. And it was also about the receptiveness of the traditional healers and also the scope of the project. It's already a huge project.
Yeah.
But maybe I didn't mention, but it was very much done within the health facilities. So it was in existing health facilities with existing health providers where we worked. So we weren't creating a new service. It was all done within the health service. So I mean, in a sense, we were working with people with services that already exist, but more the medical services rather than the traditional healers.
Because in terms of stigma also, I don't know, I was thinking that like, yeah, what were the ways, because that was also one of the points that you, that the project tried to work on stigma and
Yeah.
to improve the demand side.
Yeah, yeah. So they've, so exactly. So that's one of the approaches. The other thing that they've been doing now in Nepal is how they train primary healthcare workers. So people with mental illness come and help to do the training. And because that's one of the things that is shown to be the most effective actually in reducing stigma is to have what they call social contact. So saying that people with mental illness are just like you and me, they just also struggle with something. And also, I don't know if they've done it, but plan to include them in the community sensitization, so the awareness raising to also have people living with mental illness telling their story. The problem is when you first go into a place, you kind of almost have to go in and start a service and people need to start getting better and then they need to be okay with speaking out so that they don't feel like there's going to be too much stigma against them before they actually take part and are active voices. So it's a bit of a situation where to go into a community and find someone with mental illness and say, are you willing to speak out? It doesn't really work.
Yeah.
So I think there is a little bit of a process of creating something and some activism. And also, I mean, in Ethiopia, my colleague Abeba Fakado, he talks about the way they reduced the stigma in Ethiopia was just people got better. And people who had I think they managed to get more than 80% of people living with psychosis in the district into care, which is huge. And he talks about how just the community watching people who were previously homeless or shunned by their family being reaccepted was huge in terms of reducing stigma already.
Okay, any more questions? If not, then I will close the session for today. Thank you once again, Erica. Organization-wise, for the medical students, here's the attendance list. I don't know, are there any ladies people here? No. Oh, there's not. You should have your own attendance sheet right at inside. If not, just sign this one and just write ladies like that or something. Yeah, this one. Yeah. Next lecture will be the Global Health Society on Tuesday, where we have Kevin McCarthy on SDGs and the 12 international agencies and how they sort of strengthen the progress towards the SDGs. And the next Global Health lecture series will be on the 12th of December in the progress in maternal and perinatal health and search for the metaphix by Claudia Hanson. That's it for today, guys.
Is that the gym?
Is that the German thing? Is it weird?
It was so weird when I first
I don't know why we do this.
It was so strange.
I haven't
Last week, no,
Sorry. No, thank you. Okay, I was worried. It's when you've been immersed in something for so long as well, you forget to explain to people what seems to be quite obvious.
So I think that was very interesting.
Thank you for your questions.
Yeah, they were-
Ja, in Mannheim, in der Ehe. Und ich war heute nur bei dem Seminar mit von den Mitgliedern und ich möchte doch bleiben nochmal machen.
You reflect and then you really next time I think it's normal.
Aber sehr gut, ja, auch viel gelernt. Essen habe ich auch noch viel gelernt. Auf jeden Fall gelohnt war. Den weiten Weg nach Heidelberg.
And then you go back to it's not next.
Wenn wir das
No, 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 no.